Yeah, fine. Okay. So let's begin the session. The medical management of glaucoma, the choice. The goals of managing patients with glaucoma are control of intraocular pressure in the target range, stable optic nerve and RNFL status, and stable visual fields. The benefit of controlling intraocular pressure has been well established in our landmark studies. According to the early manifest glaucoma trial, a 25% decrease of IOP from baseline reduced the risk of progression by 50%. As per the CNTGS, the progression rate in the treatment group was 12% compared to the control group, which was 35%. Ocular hypertension treatment study also proved that the progression to POAG was 4.4% in the treatment group and 9.5% in the control group. And OHTS also gave some predictive risk factors like increasing age, baseline high IOP, increased cup disc ratio, thin cornea, and high pattern standard deviation. OHT without additional risk factors treat when the IOP is consistently above 28 to 30 millimeters of mercury. OHT with additional risk factors follow OHTS guidelines. Minimum 20% IOP reduction is needed. In pre-perimetric glaucoma, decision to treat should be individualized based on risk assessment, RNFL assessment, and constant monitoring and follow-up is mandatory in pre-perimetric glaucoma. So concept of target IOP should be clear. It's an IOP range which is identified below which further damage is considered unlikely, and this will limit the progression to a rate that will preserve visual function without affecting quality of life, and it depends on stage of disease, baseline IOP, age, life expectancy, central corneal thickness, and rate of progression. It's a dynamic thing, and periodic revision and resetting is needed. Diurnal phasing even on treatment may be needed in some cases. A lower target IOP can be justified in severe disease, progressing visual field defects, presence of risk factors. No validated algorithm for determining target IOP currently exists, and it's highly individualized. AAO recommends a 20% reduction from baseline in mild glaucoma, 30% reduction in moderate, and 35 to 40% reduction in severe glaucoma. So coming to medical management, the prognosis and management plan and the likelihood of long-term therapy should be well explained and discussed with the patient. And the things to be considered are quality of life, comorbidities, and life expectancy. The main concerns of medical treatment are adherence to treatment and the expense of treatment and local or systemic side effects. And choice of therapy is a combined decision. Systemic comorbidities that deserve consideration include asthma, COPD, cardiac arrhythmias, and depression, and pregnant and nursing patients also deserve a special consideration. Anti-glaucoma medications are classified according to the pharmacological category. Prostaglandin analogues are the first-line therapy. They decrease the IOP by increasing the uvascular outflow. Prostamides include bimatoprost, which has a dual action of increasing the trabecular outflow as well. Other prostaglandin analogues are latanoprost, travoprost, and tafloprost, and docosanoid, which is unoprostone. All prostaglandin analogues are administered once daily, either as monotherapy or in a combination with beta blockers. The most common adverse reactions are conjunctival hyperemia, iris and eyelash pigmentation. Contraindications are cataract surgery with PC, rent, and vitreous loss, herpes simplex keratitis, either active or quiescent, uveitis, and cystoid macular edema. Prostaglandin-associated periorbitopathy syndrome is worth mentioning because we encounter that very often. Include periocular skin pigmentation, hypertrichosis, orbital fat atrophy, deep upper lid sulcus, tight orbit syndrome, and upper lid ptosis. And these are more with bimatoprost and travoprost. Tight orbit can pose a difficulty in monitoring IOP with GAT, and to reduce this side effect, we should instruct the patient for proper drop application without spillage. A partial complete reversal of these symptoms have been reported in 4 to 6 weeks after treatment discontinuation. What's new among the prostaglandin analogues? Latanoprost bunoid is a latanoprost nitric oxide donor conjugate. A novel EP3 receptor dual agonist hepatoprost is there, and selective non-prostaglandin prostanoid EP2 receptor agonist omidlenapag isopropyl. Coming to beta blockers, timolol 0.5% is a first-line drug, reduces the production of aqueous humor, but the low efficacy is lower with long-term use. Systemic side effects are common like bradycardia, bronchospasm, depression, hypoglycemia. Locally, dry eye can occur. Contraindicated in asthma, COPD, more than first-degree heart block, and cardiac failure. Cardioselective is beta-axolol, but it does not completely eliminate the cardiopulmonary side effects, but reduces it. Topical beta blockers may be used once or twice daily, but nighttime dosing is associated with limited efficacy and also can cause visual field progression because of nocturnal reduction of systemic blood pressure. Alpha agonists decrease the aqueous humor production by increasing the uvascular outflow. Brimonidine increasing the UV vascular outflow as well as decreasing the aqueous humor production. Brimonidine 0.2% and 0.15% are commonly used. Side effects are allergy conjunctivitis, follicular conjunctivitis, somnolence, fatigue, contraindicated in MAO inhibitor therapy because it can cause hypertensive crisis. Brimonidine is absolutely contraindicated in children younger than 2 years of age. Topical carbonic anhydrase inhibitors decrease aqueous production. 1% brinzolamide and dorzolamide 2% are used. Adverse effects are corneal edema, metallic taste and conjunctivitis, contraindicated in sulfur allergy, sickle cell disease. Systemic carbonic anhydrase inhibitor is acetazolamide, commonly used 250 mg or 500 mg. Adverse effects are Stevens-Johnson syndrome, malaise, anorexia, serum electrolyte imbalance, renal calculi, paresthesia, which is very common, and abdominal cramps. Contraindicated in sulfonamide allergy, kidney stones, aplastic anemia, and sickle cell disease. Cholinergic agonist in use is pilocarpine. Adverse effects increases the trabecular outflow. Adverse effects are increased myopia, decreased vision, brow ache, and retinal tears and detachment in predisposed cases, and contraindicated in peripheral retinal breaks, and is pro-inflammatory, hence not used in neovascular glaucoma and uveitic glaucoma, and also in malignant glaucoma. Rho kinase inhibitors are a newer addition. Commonly used are ripasudil and etazudil. Increases the trabecular outflow, decrease episcleral venous pressure, and decrease aqueous production. Side effects are common: conjunctival hyperemia, blepharitis, honeycomb cornea as well as cornea verticillata, and conjunctival hemorrhage and instillation site pain are also there. Currently no contraindications. Hyperosmotic agents control the acute increase in intraocular pressure. The mechanism of action being dehydration of vitreous. Mantol 20% is used IV, or oral glycerol is also used. Adverse effects are headache, congestive heart failure, renal failure, mental confusion, contraindicated in renal failure, heart failure, and potential CNS pathology. Fixed drug combinations are available mostly with timolol and prostaglandin analogs, timolol and brimonidine, timolol and carbonic anhydrase inhibitors, and even the timolol, brimonidine, and brinzolamide are available. So coming to anti-glaucoma medications in pregnancy, balance the risk of glaucoma progression against concerns for safety of fetus. Data on risk are limited and is not completely safe. Only brimonidine has a pregnancy category B rating. All other anti-glaucoma medications are C rated. There is a theoretical risk of premature labor with the PG analogs. Oral carbonic anhydrase inhibitors can cause teratogenicity in animals. Rho kinase inhibitors are not assigned a pregnancy category, and no data exist on the use of them. Brimonidine may cause CNS depression and apnea in newborns and should not be used in late pregnancy near term. Monitor the fetus regularly for arrhythmia and bradycardia for patients using beta blockers. In lactation, timolol and dorzolamide are approved by the American Academy of Pediatrics for use during lactation and should be used with punctal occlusion to reduce the systemic absorption. But beta blockers are excreted in breast milk in concentrations several times higher than in plasma, so systemic cardiorespiratory side effects can occur in infants. PGA may be considered for use in a breastfeeding mother. And AGM in children, beta blockers are first-line agents in suitable pediatric cases with no cardiopulmonary issues. And apnea and bradycardia may occur in newborns and infants, so be careful. PGA has a similar efficacy. Both dorzolamide and brinzolamide are effective in reducing IOP in children. Systemic acetazolamide has a potent efficacy in children, especially before surgery. Chronic use may lead to failure to thrive, enuresis, lethargy, and nephrolithiasis. Brimonidine is absolutely contraindicated in children younger than 2 years of age. Best to avoid in children less than 6 years of age and less than 20 kg of weight. Cause CNS depression, apnea, because it crosses the blood-brain barrier, and children has an immature blood-brain barrier. That finishes my